Hi, everyone. This is Anne Flynn. Thank you for joining. Zena is dealing with kind of an urgent situation, so she may pop in and pop out at some point. And I'm also here with Ina Papo, and I thank her for helping us with this presentation and all the work she's doing on education. Also, Max is helping with the presentation, and Choi has done so much work with the SharePoint and this presentation. So I just want to thank everyone that was involved. So the purpose of our COVID-19 University presentations is really to help you all, educate you all. We know that there's a lot of information coming at you from various resources, not just from Northwell, but television and media and social media. And it's, been difficult for everyone, I think, to try and digest. And, we know you are on the front lines and responsible for handling a lot of the patients' questions and answering them. And so the purpose of these talks is to give you the most current, best evidence-based information that we as Northwell are going by. So our first talk is about clinical care coordination of COVID-19 patients in the community. And I'll give you a little bit of what the agenda is. Also, I should remind everyone you can type in your questions, and Ina's going to be monitoring that. And there will also be should be time for questions at the end. I'm also going to go through some frequently asked questions at the end. So for today, we're going to do a general overview of COVID-19, what it is, how it's spread, the current state of the disease. We'll go into testing a little bit. We'll go into some care coordination scenarios and guidance, some review of the patient education that the patients are getting from Northwell. And then, as I said, some FAQs, open it up to some general questions, and then we'll just remind you about our Health Solutions SharePoint. So to start off, just the basic facts. It's so important just to know this, and I know a lot of you probably do know some of this already, if not much of the beginning of this. So what is the coronavirus? It's a large family of viruses, as you probably know by now. Some coronaviruses cause the common cold, and so it's really quite common. What happens is that it can also cause these other severe diseases such as MERS and SARS. And now we have our novel coronavirus 19, which just basically stands for coronavirus disease 2019. And it is a respiratory illness that can spread from person to person. And it was first identified, as you probably all know, in this outbreak in Wuhan, China. And again, all this information is available on our Health Solutions SharePoint, which we'll emphasize at the end as well. So right now, what is the state of the cases right now? So worldwide, you can see here there are 334,981 cases in 190 countries around the world. In the US, there are currently 33,404 cases, and in our area, New York State, there are 12,000. Total cases in Long Island right now is about 2,000. Total cases in Westchester right now is about 1,300. And right now, in our Northwell facilities, we have had 638 cases test positive. So how is it spread? So mainly it's person to person, right? You have to have close contact with the person, meaning less than 6 feet usually. It's spread through droplets, by coughing, by sneeze. If you touch your face, it can get into the droplets can get into your membranes. And the surfaces which have been talked about, such as your counter, your doorknobs, can be a source, but thought to be, pretty minimal in comparison to the person to person. But it is, of course, important to keep everything sanitized as much as possible. How do you know if you have it? So you may have the symptoms, which will go into the shortness of breath, the cough, the fever, and you may have had contact with someone that had COVID-19. You'll consult with a medical professional, and they will give you advice. Right now at this time, and we'll go into testing maybe a little bit more, but widespread testing is not actually recommended at this time. If you are sick and at home and you're having these symptoms and you don't need medical attention, meaning you're not extreme in duress and need to be seen by your doctor or worried that you might get worse, the recommendation is really to stay home and treat it like the flu. And testing, really occurs mostly in the hospitals to know exactly what we're dealing with in the hospitals, whether we need to maintain these isolation precautions in the hospital, and because that does use resources. And also right now, the routine RVP test is no longer recommended. Before, they were doing that first to make sure there wasn't a flu or something else going on. But because in the last weeks or so, they've found that the flu has really, really dropped off, and the RVPs are really coming back negative, and they're saying just start with the coronavirus test at this point. If that's negative, you can use the same nasal swab to test for the RVP. So symptoms, as I said, fever, cough, shortness of breath, fatigue, these are the main symptoms being reported. You, of course, can see other symptoms as well. Some people report GI symptoms, headache, myalgia. There are different severities of our illness. There's people in the community with mild symptoms, and it's important to remember that most people with coronavirus are being managed in the community. They are not in hospitals. They are not in our ERs. And those that will be hospitalized, a percentage of these will need intensive care units because of respiratory failure. The most at risk are our elderly, and the elderly in nursing homes, also elderly with comorbid conditions, and immunocompromised patients. It's important to remember that whether these people are in the community or have been discharged from the hospital, they'll need our help. So we're going, this whole population, is really needing our support and our help at this time. And, I'm hearing from the TCM staff that they're getting, a lot of calls to, help with concerns about the illness. Why are we so worried about this COVID-19? First of all, because it's begun to have this community spread, meaning it's being transferred person to person within the community. You don't necessarily have to have traveled from China or anything like that. It's right here in our home base now. The level of infectivity, meaning that it seems to be able to infect people at a fairly high rate. And then there were and are concerns about mortality. At first, it was thought that this had a higher mortality rate. Now it's looking like, now that we know the amount of cases, more of what is out there, that the mortality rate is now looking like it's closer to what a typical influenza season would look like. But they're still analyzing that. So COVID-19 testing guidance, if the test is pending, you're considered a person under investigation, PUI. There will be isolation practices and precautions should be maintained. This is so in the hospital, they would maintain isolation practices. At home, you would maintain isolation or what we call quarantine practices. If the test is positive, you'll continue home isolation until you're completely well. You have no fever for 48 hours, or 72 hours, sorry, 3 days, and it's been at least 14 days since your positive test. If the test is negative, you will be able to stop home isolation and resume standard precautions, similar to how you would manage a common cold or flu. Are there any questions coming up from this, Ina, that I should answer now, you think?
No questions yet.
Okay. So we're going to just look at what's happening when a patient is ready for discharge, so that you know what's happening in the hospitals, when they're being discharged from the emergency room, or when they're being discharged from the hospital. So when a patient is seen and discharged from the emergency room, they'll be given information from Northwell, all available on our SharePoint, so you'll know exactly what they're getting. The plan, if we're planning on following some of these COVID tests, and the plan is for a 24-hour follow-up call, a 48-hour follow-up call, and then from day 5 to 8, we would want to, day 5 and day 8, we want to do another follow-up call. Why do we want to do that? Because it's been found that people can appear that they're doing okay, and then around day 5 to day 8, they can suddenly decompensate, become more short of breath, hypoxic, their oxygen level is low, and this is why this seems to be some key period within the disease process, and we want to be able to monitor that and see if the person kind of makes it through that time period. So you might see this shortness of breath, the low oxygen, a worsening fever, a cough. Also concerning would be confusion. Is the patient lethargic? Are people having difficulty waking him or her up? Does he actually appear, you can actually appear bluish, around your lips. And any clinical, any sign of a worsening symptom should be escalated to a clinical supervisor. So the final call would be with recommendations to discontinue quarantine, and that would be in conjunction with a clinical supervisor as well. And we could be able to advise the patients on when they can discontinue quarantine. So normally it would be, as I said, 14 days after the positive test, plus afebrile for 3 days, and other symptoms are improving as well. The cough does not have to totally resolve. They might have a residual cough for a while.
So, and we have 3 questions so far.
Okay.
Around the incubation period and testing. The first question is, I just wanted to clarify around the time frame a COVID positive patient can shed the virus or is contagious. I know literature states the virus can shed up to 20 days, and I just wanted to understand the 14-day isolation is in relation to guidelines.
Yeah, I mean, this is based on, the CDC.
Hey, Ann, we have a couple of questions.
Yeah. Ina just told me a couple of them. Is that what you're referring to, Max?
Yeah, go ahead, Ann.
Okay, so the 14 days is what, we're going by what is recommended by the CDC and the World Health Organization, as, in terms of shedding. So the 20 days, I honestly had not heard of myself, so I'm not sure what the source is on that, but I assume that they've found the majority of infectivity would be within this 14-day period.
The second question is, there are community providers who recommend COVID-19 testing for mild symptoms and patients are being directed to urgent care for testing. Are community providers updated with these guidelines for testing, or are these Northwell guidelines for testing?
Good question. So all the questions around testing kind of change day to day. And it's a combination of Northwell, CDC, World Health Organization. The community providers should be educating themselves on what the guidelines are. However, they may choose to recommend a test for someone. They that's their right as a provider. And I know the information out there is very conflicting around the testing, but right now the testing of someone who is just having symptoms and is at home is seen as not needed, basically, because they are not decompensating and in need of hospitalization.
Do we know the incubation period yet? How long can the virus be active before symptoms show?
There's conflicting, good question. There's conflicting evidence on that too. I've seen 3 to 5 days. But it's thought, and it's what has been found is that it's most infectious when the person is having symptoms.
And I think you should move on with the presentation. We have a couple of questions that I think other people will be able to answer, and I see one question that I believe you have a slide on that will answer that question.
Okay. Thank you. So here are some scenarios of patients being discharged from the hospital, just so you're aware what the nursing case managers are doing. They also have very detailed information about this in our information on the SharePoint. But so you have the scenario of a COVID positive patient being discharged to skilled nursing facility or assisted living facility. COVID positive or person under investigation being discharged home and requires home care services. COVID positive patient discharged home with no Northwell home care services, and COVID negative patient discharged home or to nursing facility or assisted living facility with or without services. And basically, there's an asterisk there because the patients who have been discharged without any services will need our support even more. I'm just going to focus on one scenario of interest, which is the COVID positive patient or person under investigation being discharged to skilled nursing facility or assisted living facility. Right now, the New York State Department of Health is recommending that the patient has to have 2 negative results 24 hours apart before returning to the skilled nursing facility, and they have to have resolution of fever, and that is without the use of Tylenol or Advil or anything like that, and overall improvement in illness signs and symptoms. So this has been a big issue, as you can imagine, for throughput in the hospital. These patients are waiting, they're clinically stable, but they're waiting to have these negative tests. And so Northwell is starting to move some of these patients and has successfully transferred some of these patients to Glen Cove Hospital, where they have a unit for these patients who are waiting for their negative test results in order to go back to these facilities. Right now, there is no recommendation that other patients other than these patients have a negative test result or a repeat test to show that they're negative. So this is kind of some of the education that most of you are probably familiar with and is available and given to the patient. But most importantly, we want to emphasize to the patient that if they have any questions or concerns, that they please call us and we provide them with that phone number. So how to keep yourself and others safe at home. You might get questions about this, and the details are: avoid sharing personal household items, clean all high-touch surfaces, that's keyboards, doorknobs, countertops, and separate yourself from other people and animals in your home. You know, if you have a separate bathroom, that's ideal. Wear a face mask when you're around other people. If that's uncomfortable for someone who's short of breath, we recommend that the other people wear the face mask when they're around that person. Cover your cough and sneezes. Clean your hands often with soap and water for 20 seconds. And how to prevent spread in the community. We've been hearing a lot about this lately, right? But particularly for someone who is a person under investigation or positive or having symptoms, they should restrict activities outside your home except for getting medical care. Call ahead before visiting your doctor. Avoid using public transportation, ride sharing or taxis, and don't go to work, school, or public areas. Something the patients are given when they're discharged is this self-monitoring log. And they're instructed to monitor their symptoms and seek prompt medical care if illness worsens. So they keep track of their fevers, their coughs, sore throat, whether they're short of breath. And this is just a reminder to consult a provider before discontinuing home isolation 14 days after a positive test. The recommendations differ for Northwell employees in clinical settings, and I'll get to that later in the presentation. So I'm just going into some frequently asked questions here. How is close contact defined? Which is being within approximately 6 feet of the person with COVID-19 for a prolonged period of time. So if you're caring for a patient or visiting a patient, of course, if you've had some sort of unprotected direct contact with infectious secretions or excretions, if the person has coughed on you or you've touched used tissues with a bare hand. And there's a timing to this too. You know, generally it's considered the contact would be over 10 minutes or more to be considered significant. So this is a question. We are working with employees, so I know our team has gotten some of these questions from Northwell employees. And these are the current recommendations of when a Northwell employee should return to work. If they are a team member in a care setting, mean they work in a hospital, they work in a doctor's office, the recommendation currently is 7 days after a positive test or 7 days after the start of symptoms, and no fever without use of antipyretics for 72 hours. Team members in all other settings, for example, if you worked in finance or something like that, you go with the general community recommendations of 14 days after a positive test and no fever without use of Tylenol or Advil for 72 hours and other symptoms are improving. This all has to go through HR though, of course, when the person returns to work. They have to contact HR. Contact of a contact. So this is a frequent question from patients and others. My friend or family member was exposed to a confirmed COVID-19 patient, but does not themselves have symptoms of fever and cough. I've had close contact with this friend or family member. What should I do? So right now, the Center for Disease Control does not recommend testing, symptom monitoring, or special management for anyone exposed to asymptomatic individuals with potential exposures to COVID-19. So that's considered a contact of a contact. And yeah, there's no special management or testing recommended for that. Is there a treatment out there? There's no established treatment for COVID-19 at this time, other than symptom management, as you would the flu. At Northwell, we currently have 2 clinical trials underway, an antiviral Resdinovir and the IL-6 receptor inhibitor, which is usually used for rheumatoid arthritis. So these are the 2 clinical trials going on right now. The IL-6 receptor inhibitor is not an antiviral. It works by suppressing what's called cytokines in your lungs, which are what causes inflammation in your lungs. So this is something that's being used on very sick patients in the ICU to see if they can reverse this acute respiratory distress syndrome that they have possibly gone into, and that's where that is being used. You'll see other medications being prescribed and used. Azithromycin is out there. There's no evidence at this point to support that helps or is working. You'll also see the anti-malaria drugs, chloroquine and hydroxychloroquine, being used. This hydroxychloroquine is also called Plaquenil. It's used for lupus. And the problem is this is very much out there in the media and people are asking their doctors for this and everything. And the concern is that patients with lupus might lose their access to Plaquenil, and some are quite dependent on it for symptom management. So at this time, Northwell is working on a policy for the use of Plaquenil in the hospital for COVID, and pharmacy is monitoring that pretty closely. Is there a vaccine? There's currently no vaccine for COVID-19, but there are several agencies working on this. So, oops, sorry. This is just, do you want to comment on the SharePoint?
Sure. Hi, everyone. This is Ina. We have a place now on our education SharePoint where we placed all the important documents regarding COVID-19. And these documents are about discharge planning, care coordination, all the up-to-date documents on patient education. We have something on newborns being born to COVID-19 mothers. Of course, we have a section on employee well-being resources. So a lot of FAQs, stress and anxiety presentation by wellness with good resources, some good articles. The EHS, EAP numbers are there. The mail order pharmacy number is there. So we really tried to make it very user-friendly. So you have one place to go to for all your up-to-date documentation related to COVID-19. We also have section for children, adolescents, and family, telehealth resources, how to bill for telehealth, and guidance for Medicaid providers. Of course, also infection control, our policy on infection control, and the self-learning modules that I'm sure you're familiar with. So I encourage everybody to visit this SharePoint site and to use it for the up-to-date documentation. Thank you.
Thanks, Ina. I'm not sure, is Zena on or no?
Yeah, Zena's been answering questions. So a lot of Q&A came in. We had Dr. Jen and Dr. Brown who've been answering questions. I answered a couple.
Oh, okay, great. Are there any unanswered questions right now?
Probably. I'll go from the end. I have a patient on Plaquenil for management of her SLE. I suggest she make sure that she has 90-day supply on hand, which she does due to possible future demands. So I guess this is more of a comment.
Yeah, that would be a good recommendation.
I have a question. Are you immune to this after if you get it and you're positive and you recover? Are you immune from there on?
That's the unknown. I answer one of those questions. So you're not alone, Jeff. I know everybody wants to know. I believe at this point, they don't know for sure.
Okay, thank you.
Right, they don't know because you know, it's similar to the flu and how the virus changes and all that. So there isn't a definite answer on that.
Yeah, I see Dr. Brown answered a lot of questions. I think also there was a question, what is the reasoning behind 7 days post-positive test for healthcare professionals going back to work? Wouldn't that put patients and other providers at potential risk?
Yeah, that's a good question. And it does seem, like a disconnect. Why are some people 14 days? Why are some people 7 days? But apparently Northwell, this is an evidence-based decision that at this point, if the person is not having symptoms and 7 days has passed, that there's a very, very, very low risk that they would be shedding the contagion. But of course, part of the reason behind it is because we have so much of our workforce dropping out, and we do need our workforce back, when it seems reasonable for them to be able to come back.
Max, if you could help to unmute Dr. Brown. There was a question for the test. Is it possible to have a false negative?
The chance of a false negative is very, very low. And the only situations where we would retest is if we couldn't find another reason for the illness, that the person had some high risk factors. For instance, we know they were exposed to COVID-19 and or traveled from a high risk country, and we hadn't been able to find another reason, we would retest. But it's been a very small number.
Yeah, I think Dr. Brown and Dr. Jen really answered a lot of questions that came up. It's just hard to keep track as they kind of mix in together.
Max, are you able to unmute Zena, or what's happening?
Hey guys, so it's not that simple. I don't think the right phone number is available, or I can't at least find it, and I can't unmute it. So she might have to use either like the *67 path or use the link that I originally sent in the first email to presenters to join that way through MS Teams.
So I would just
Hey
like
guys,
to.
I dialed in. If you wanted to unmute yourself, just press *6 from your phone, and you'll be able to speak. All right, yeah.
Oh, no, thank you. This is very helpful. I just wanted to encourage everybody to read through the answers, because even if you didn't ask the question, we do have some really good information here. And really the idea of this presentation is to give you up-to-date information. As you know, things are changing from day to day, but our SharePoint has the up-to-date documents. This presentation has a really good information. And we wanted to give you this forum to ask questions. If you feel that your question was not answered, if I accidentally skipped through it or somebody didn't answer, please email me and I will send it to Dr. Flynn and Dr. Brown to answer if you feel you didn't get the answer you were looking for.
Yeah, and also, you know, we went over the discharge documents, but if you go into the SharePoint, you can see exactly what is being given to the patient. And I would, you know, just familiarize yourself with them and have them at your ready when you're speaking with patients.
There's one question just came in. Are we able to see at this time if the majority of hospitalized patients with COVID are high risk, or are they a mix of healthy and high risk patients?
The majority are high risk patients. You know, we have seen some cases of people who you would not consider high risk, but yes, the majority would be high risk.
Somebody also brought up a good point that we've heard about also this morning. Any resources to obtain Tylenol, our patients cannot get it at the retailers. We are aware of shortage of Tylenol in some of the pharmacies. And then also mass PPE for patients and family members for when they go home. That's going to be a difficult one.
Yeah, I just started to hear about this this morning, that the patients were having difficulty finding Tylenol. If they're being discharged from the hospital, we might be able to take advantage of Vivo Pharmacy being able to supply that, and or the provider on discharge writing a prescription and the pharmacy doing it that way instead of over the counter. But I just became kind of more aware of that issue this morning, so we are looking into that.
That's great. And also Dr. Brown had a great idea. What we're going to do is, once we wrap this up, we will write it up. So all the questions that came in, so if you didn't see the answer, we will put those questions and answers and we'll send to the group.
Great. All right, then I think we can, you know, finish up the presentation. If you want to continue writing in some questions for the next 10 minutes, that's fine. And I hope this was helpful. And yes, much of this information is going to be available on the SharePoint. And we will be hosting other informational sessions such as this in the future. Thank you, everyone.
Thank you.